in relation to COVID long haul, some scientists have proved a connection between micro blood clots and a fast high pulse, fast heart rhythm, and all the other symptoms what patients are suffering. What is your, do you have any comments to this? Is there a connection?
One general comment is that one of the things that I think we are all hoping for is that with the intensity of the amount of scientific study of COVID and long COVID, that some new understandings about the mechanisms for ME will emerge. Our patients with long COVID all really look after 6 months just like everybody pre-pandemic, right? We don't see it as being a distinctive illness, long COVID. It's really, by the time they reach 6 months, they have the same impairments as our patients who got ME after Epstein-Barr virus or something else. But because people can study the disease as it's evolving, we're seeing these observations emerge about immune function, autoantibodies, and the microclots. I'm only aware of the group from South Africa reporting that, and I think in science we want to see replication of research findings, but that may provide a way of treating long COVID with anti-clotting drugs that potentially could be expanded to those who have microclots in the ME/CFS population. I don't think we're quite there yet. I would like to see more replication and more data from randomized trials of treatment, but I'm very excited by the amount of work being done on long COVID and optimistic that this will apply to many of our patients who we have not been able to help using other measures.
Great, thank you. Next question. Do you know about the research project for Gittleman's syndrome and POTS at the Stanford, and whether you yourself sees this as a possible connection?
I'm not aware of that study, but I think it's an example of all of the work that's being done on subsets of people with these different disorders. You know, we've focused a lot on the Ehlers-Danlos syndrome group. I'm not as familiar with Gittleman syndrome, so I'll have to look into that. Okay.
So third question, hypermobility and ME and POTS, if not fulfilling Ehlers-Danlos criteria. Is that well known to you?
Yeah, and you know, we looked at we had a paper last year where we took our cohort study where we had 55 new adolescents and young adults with ME/CFS, and we divided them into a group with a Beighton score of 0 to 3, so not hypermobile, and those who were 4 or higher. And our expectation was that the patients with hypermobility would have come in at an earlier age, not as often with an infectious onset. They would be more severe and they'd have more problems with quality of life. It turned out that the two groups were normal, that were equal on all of those things, much to our surprise. It may be that it was just too small of a study because Dr. Van Kampen and Visser have a larger study of 100 patients with hypermobility and ME and 100 who didn't have hypermobility. The hypermobile patients had a much greater reduction in their brain blood flow. Mm-hmm. But it may be that the Beighton score that we used isn't an adequate way of discriminating the flexibility and laxity in the blood vessels. It may be that part of what predisposes people to ME is this increased pooling of blood because of how lax the vessels are. And that it may be possible for that to occur in the absence of true joint hypermobility. So I think we need more work on that.
Oh, great. Thank you. So next question is a patient-related question. She asks, I'm one of the few ME patients who doesn't get a normal POTS reaction. When standing up, I get a very elevated blood pressure and a high heart rate, and this doesn't go away until I lie down again. If I stand still, I get cold sweats, nausea, and as if my blood sugar drops. Is there an explanation for this opposite reaction?
Yeah, there's a condition called hyperadrenergic POTS, which is defined by an extremely high norepinephrine or noradrenaline level. and noradrenaline helps with vasoconstriction. So in people with hyperadrenergic POTS, you'll see an increase in heart rate, but you see actually an increase in their blood pressure when they stand. So that's quite consistent. What you're describing is quite consistent with orthostatic intolerance in general, but with the hyperadrenergic POTS in particular. And many people try to treat that with beta blockers, clonidine, and similar medications. But that's a known subtype of POTS.
Okay.
I'm going to go back to the other question. I don't think I answered the whole hypermobility question adequately, but there's a spectrum of joint hypermobility, and it's important to look for that. The difference between just being hypermobile and meeting the criteria for Ehlers-Danlos syndrome sometimes is in the eye of the beholder, and the criteria for separating them are poor and probably don't exist. That there's just a gradual spectrum of increased joint laxity with EDS hypermobile type at the extreme end of the spectrum.
I'm asking, will it be helpful to take collagen as a supplement to help strengthen your tissue?
I don't know if I know that people have tried that. I would think the collagen would get broken down in the stomach and in the process of absorption, and it wouldn't really help the connective tissues. I think people are always looking for something that would help improve the joint laxity and the connective tissue laxity, but we're not. I don't know of anything in particular that would do that. I don't think taking collagen would hurt, but I'm not aware of data showing that it would be truly beneficial.
Next question is, when general or local anesthesia doesn't work enough or long enough, as it is the case for some patients, can it be related to ME, Ehlers-Danlos, or CCI?
There have been several papers through the years on the fact that local anesthetics like lidocaine don't work as well for some people with Ehlers-Danlos syndrome. There's been some debate about whether that's a valid finding, but we hear it often enough that I think there must be some truth to that. So I would relate that more to the EDS than to the CCI.
Okay. I just jumped a question. Somebody would like to know, you talked about wanting to have the patients to be more active, like they were before getting ill, but you described that patients are more tired and exhausted at the start of their illness. Does it mean that you can expect that this tiredness or exhaustion will evaporate after some time, and you'll be able to be more physical again?
So those are the hopes and the goals, I think, of all patients and all physicians as we treat these problems. The reality is that there's some that we have been unable to help, and where they're homebound, and if they exceed their usual activity level, they generate post-exertional malaise. So they have to really pace themselves carefully. But in the patients that we are able to support the circulation and they can tolerate expanding their activity, the hope is that they can get back to where they were before. That's probably not as common as we would like it to be. But as an example, we had a boy that was unable to do his sports and really was housebound by the end of the time that we were seeing him. We identified a Chiari malformation and sent him for neurosurgery, and this led to a big improvement. And he came in 6 months after the operation and said, I said to him, how are you doing today, Ben? And he said, oh, I feel about the same. And his mother just about whacked him in the shoulder and said, Ben, tell him what you did yesterday. And he said, well, we went out and played 18 holes of golf. And then we came back and swam. And then we played basketball for a bit before going out to the movies. And he said, but I still feel tired. So what he had done was, as he felt better, he expanded his activities in a very healthy way, but he's willing to tolerate enough the fatigue, and that was the last symptom to disappear. And I think that's an important lesson, is that the fatigue is something people get used to, and maybe the thing that leaves latest once they've completely recovered. But I think what this boy did was very healthy in response, and that was to be more engaged with those around him and to be more active, and tolerate a few symptoms.
Okay, thank you. So Lina asked you if is it possible that you could share a list of the studies that you have mentioned in your speech now for those interested?
Yeah, I'll send those as PDFs.
Great. Somebody wants to know about the hiking girl. Did she also have ME?
Yeah, she met all the criteria.
Somebody here wants to ask, she's a POTS patient here in Denmark, and she asked that in Denmark you're only being offered beta blockers and are being told to eat more salt or drink water by your general practitioners or in the hospital. Do you have a suggestion to what can be done more and what could be offered as right treatments that you are talking about?
Yeah, and maybe one of the recent state-of-the-art papers from the National Institutes of Health here in the U.S. that came out last year, a paper that a number of us that treat POTS were part of. But this endorses the range of therapies that I mentioned to you. I think it's shameful to only offer beta blockers. They don't work for everybody, and some people are sicker with them. And if you're going to allow treatment at all with medications, use the whole range of medicines that are effective. It doesn't make any sense to deny people the opportunity to feel better. And I will say at this point that I'm not opposed to cognitive behavioral therapy as a treatment for people with anxiety or depression or coping problems. But the idea that it could possibly be curative for this illness is fanciful, and it has been imposed on patients with ME/CFS without good evidence for over 3 decades, and it's just a horrible idea. Horrible. And there is just no justification for it. It has been dropped even by the UK guidelines. The NICE guidelines that came out no longer suggest CBT as a primary treatment of ME/CFS. Finally, they said that. Their prior NICE guidelines were equally horrible because that's what they went to as a first-line treatment, and it just doesn't work. There's no way it could work if you think about it, and it doesn't do anything for the main problem of orthostatic intolerance in these patients. How is talking to a psychologist going to get better blood flow to your brain? It's fanciful.
We totally agree, and yet the National Health Board has refused to follow the new NICE guidelines here in Denmark, but we are working on that.
Yeah, good.
Next question, can you say something about COVID? What is the risk for unvaccinated ME patient with comorbidities as POTS, JH, and possibly mast cell activation syndrome?
So we've been struck by the fact that none of our existing ME patients who got COVID have gone on to get prolonged long COVID on top of everything else. That is, they didn't get a severe exacerbation of their symptoms. And I think part of that is that we were already treating their orthostatic intolerance, and many of them were on things like antihistamines and famotidine and montelukast and other drugs addressing the mast cell activation. One of the theories proposed by Dr. Afrin is that in people who, in the general population, there are lots of people out there who have undiagnosed and untreated mast cell activation that nobody has addressed. When they get COVID, that infectious stimulus causes the mast cells to overproduce cytokines, cause enormous inflammation and lots of tissue damage. So he thinks some of the most severely affected COVID patients in the acute phase are ones with undiagnosed mast cell activation. And it's possible that by using treatments that include famotidine and antihistamines and other things that quiet the mast cell reaction, that you get not only a milder acute illness, but you're less likely to have a prolonged exacerbation. So that's a hypothesis at this point. It's not proven, but we use that information to suggest very benign treatments to our patients who have active acute infection, namely get an antihistamine, get famotidine, and consider other things like nasal cromolyn that's available over the counter. And thus far, we have a sense that that might be helping, but this was not a randomized controlled trial. It's just trying to do something reasonable in the setting of uncertainty that we all face with COVID.
Right.
I think, my comment is the best way not to get long COVID is don't get COVID in the first place. But we use in people who do get COVID these days, if they qualify, we give them the antiviral Paxlovid. And that seems to be helpful in improving the speed of recovery.
And do you dare say anything about the Pfizer vaccination?
I think the vaccinations probably help reduce the overall severity of these prolonged symptoms after you get a breakthrough infection. But I think while we can think in global terms about the vaccines, that they really reduce the death and severe disease from this illness, they're imperfect in the sense that some people, like with other vaccinations, the vaccine can be a trigger to POTS and other symptoms. And I think we've seen that. We are not anti-vaccine at all. And I think you have to look at the greater good of the entire population. We don't want people dying. We don't want them getting ME or other symptoms either after the vaccine. But as we've seen from other vaccines, some people will get Guillain-Barré syndrome after influenza vaccine, but it doesn't mean that we stop giving influenza vaccine. It's an unfortunate outcome for that individual, but as a population, we're all better off by taking the vaccines.
Yeah. Next question. Are you aware of anyone doing research between the immune dysregulation and acquired connective tissues problems? I strongly believe this group is actually very large.
Yeah, a great point. There have been a couple of papers emerging where people have questioned, can you get an acquired joint hypermobility? Because the mast cells release a variety of enzymes that break down protein. And so some have speculated that there might be this connection between the mast cells and the EDS in that direction. We know that people with EDS also are much more likely to get mast cell activation for reasons that are unclear, but that's a big part of our clinic population. Is we see much more mast cell activation in the ones who are already hypermobile. So I suspect you're right. I know that Carmen Scheibenbogen's group in Berlin is doing a lot of really good work on all of these interactions between orthostatic intolerance, autoantibodies, and endothelial dysfunction. So they've been incredibly productive. I really like the literature that they are producing. And I think we're lucky to have so many good new investigators in this field that are exploring all of the possibilities, like the one that your question raises.
Yes, I agree. She's very high valued here in Denmark too. Same person who asked this question asks, can you talk more about this use of vasopressin with people having large urine production during their sleep and wake up dehydrated? Is the drug safe?
Yeah, so we use the one that is available here is called desmopressin acetate, or often abbreviated, at least in this country, DDAVP, or AVP stands for arginine vasopressin. So these vasopressin in the body helps decrease our urine production. So if you give this drug at night and you reduce the amount of urine that's produced, you're keeping more of that volume of blood in the bloodstream so that you awaken in the morning in better shape from an orthostatic standpoint. You have to watch, though, that if you're using this, one of the consequences can be a drop in sodium levels. You basically dilute the blood with too much water. And some people are quite sensitive to it. So we had one nurse that we were treating. She liked the effect of 0.1 milligrams at nighttime, and she wanted to go to 0.2. And then over the next 2 weeks, she became very confused and really was struggling. And it turned out that her sodium had dropped well below the normal range, and it was just too much desmopressin. So you really have to watch that carefully because of that known side effect.
Yeah, I understand. Last question. Is it possible to recover or just get a bit better if you have CCI and you are not getting the operation, for example, through physiotherapy? Can you like train yourself out of it?
I think that's a great question. I'm glad that you brought that one up, because we have I think we're all struggling in medicine and surgery to figure out what are the indications for surgery. And are we just measuring hypermobility at the top of the spine, or is it always, when you see the increased rotational angles of C1 on C2, is it always something that you need to treat surgically? We don't think so. Our surgeons say that in order to qualify for the surgery, you need to have pretty severe neck pain and headaches, sort of 7 out of 10 severity. We've got a number of patients with a radiologically proven CCI and atlantoaxial instability who aren't sick enough or impaired enough to warrant surgery. Nobody would do surgery on them because they're fairly functional. And we've had several who have been helped by different kinds of physical therapy techniques to strengthen the muscles around the neck. And what we don't know is which patient that we start off with is going to benefit from the conservative measures. So I think this field has to evolve. There's got to be a lot more attention to this kind of this process of figuring out who benefits from the surgery. I would say that about 80% of the patients we send for surgery for AAI or CCI would easily say that they're doing much better and would do the surgery again. Unfortunately, the occasional patient gets into a problem with chronic pain. And so we have to be really cautious about what the risk of that might be. And some don't enjoy the improvement, even though the surgery looks like it was done quite well. So I think there's still some uncertainties. It's a bit of a gamble for each individual patient, right? You don't want to be the one that gets worse afterwards, even though most people have some improvement, at least the ones that we send for surgery.
And it's very expensive surgery as well.
Correct. Yeah. And still controversial within the neurosurgical community. So some people are just very slow to adopt new ideas, and there's a bit of resistance that way. That's unfortunate. We need those people to get involved in asking the questions of who are the right candidates for this, because as you saw from the one nurse that I presented to you, she gets her life back from this surgery, and otherwise she was being blamed for her symptoms, which was completely unfair.
Exactly. So this one is from another patient. She's asking about bladder function. She writes, in addition to my hyperactive bladder, I also have bladder spasms where I can't pee at all, as well as periods where I can only pee at a very slow pace. Is this all connected, or are there multiple reasons?
So there might be several reasons, but among the ones that we would look for are these venous problems. If you get a lot of venous backup and blood pooling in the pelvis, it can affect the urinary bladder. So the people with pelvic congestion syndrome usually talk about urinary urgency that gets better after they've had the vessels ablated through the transcatheter approach. But a second area of interest is that many people who have the Chiari malformations also have a tethered spinal cord. At the base of the spinal cord, there's a thickening or a tethering that's not always obvious on an MRI. And there's a condition called occult tethered cord, where you can get a neurogenic bladder. So you don't sense the need to urinate, or the bladder gets so distended that it can't contract well. These patients can have difficulty initiating the urine stream. They can have a lot of hesitancy with urination. They can have urinary accidents. And many of them have problems touching their toes if they're sitting with their legs straight out. So they have a lot of, they might have had a lot of growing pains, as they're called, in the legs. We've even had patients who have problems with bladder irritability as they go upstairs, because that must be yanking on the tight tethered cord. And those patients can be investigated using what's called a urodynamic study that looks at the way the bladder and the bladder nerves and muscles function. An ultrasound could show you that the bladder is over capacity, and pediatric neurosurgeons and other neurosurgeons can look at the tethered cord question, but it requires a very experienced eye sometimes to identify the ones with the occult tethered cord. But if you're again successful in selecting the right patients, those patients can have a nice improvement in bladder function if that was what was causing their problems.
Okay, thank you very much. Last comment. Thank you for getting early up and talking to all our members. And can you please, somebody wrote, can you please move to Denmark and teach the doctors here?
I will guarantee you that my wife will have the bags packed if Donald Trump is reelected.
Okay, you're welcome.
I think we have a deal.
Okay. Can you briefly explain CFS leak, a tethered cord syndrome? Can it occur after lumbar puncture?
So in the patients with Ehlers-Danlos syndrome, the dura, which is the lining that keeps the spinal fluid in place and surrounding the brain and the spinal cord, the dura is a much thinner membrane. So patients with EDS can have spontaneous tears in the dura that allows the spinal fluid to drip out. I'll give you an example. One of the guys I trained with was an anesthesiologist. He was preparing the operating room tables. He slipped on a wet patch on the floor and his head banged against the corner of a stainless steel table. And it wasn't too bad. He continued on, but over the next few weeks, he got more and more fatigue and more symptoms. And his colleagues said, "Oh, you're just a wound tight, nervous guy. This is all behavioral." And he said, "No, I feel sick." And finally, one of his eyes started to deviate in. So we knew he had a cranial nerve problem. And they looked at him and he had a spinal fluid leak from the area where he'd had the head trauma. And so, it can begin quite gradually, but that occurred with trauma. The EDS patients can have these spontaneously. And the spinal fluid leaks present with terrible orthostatic headaches. People sit upright and there's no spinal fluid cushioning the lower part of the brain. So it's right up against bone and it creates the physiology of a Chiari malformation and all of the symptoms that you could see with a Chiari malformation, but it's from the lack of spinal fluid. So a lumbar puncture is a way of putting a hole in the dura. And many people get a post-lumbar puncture headache where they have to lie flat for a while. But in people with EDS, we need to be careful that lumbar puncture doesn't lead to a prolonged spinal fluid leak, because these can be quite debilitating. Another related area that people are getting more and more interested in is areas of venous obstruction to outflow from the brain. So you can have stenotic veins or veins that are compressed at the level of C1 by a very tight and ossified bone, and that's called Eagle syndrome. And some of those patients, because of the venous obstruction to outflow from the brain, have a buildup of spinal fluid pressure that then can lead to spontaneous leaks of spinal fluid. That that corrects the spinal fluid increase, so they might feel better for a while the leak is there, until the leak gets severe. And then if it heals up spontaneously, they build up pressure again. So patients with these cerebral venous problems are only in recent years being recognized for that. But they can have problems like ringing in the ears, difficulty with head pressure, and other symptoms. And I just interviewed somebody the other day who had been diagnosed with Eagle syndrome about 16 years ago, but nobody had connected that to his recent problems with cognitive fogginess, lightheadedness, and ringing in his ears. So that's an area for very specialized medical providers to weigh in. But this is another group that has been mischaracterized and blamed for their symptoms over the years, when really they had something very real going on. Thank you for the invitation. I love sharing what we think we've learned over the years, because some of my colleagues are not interested in hearing it, but we think it's so valuable, all of these individual lessons for how interesting and vast the problem of ME can be, and how different it can be from one patient to the other. So a chance to talk to people who are interested is always welcome. So thank you very much, both of you.